meeting, a scientific committee meeting. So what we can do is, rather than start the competitive section, we can start the keynote address. Do we have Dr. Rupa Gupta here? Yes, please come. She got the Glaucoma Award in the first midterm conference in Patna on factors affecting compliance to anti-glaucoma medication during COVID-19 and its effect on progression. Dr. Rupa.
Thank you, ma'am. Good morning, everyone. So I'm going to present the topic on factors affecting compliance to anti-glaucoma medications during COVID-19 and its effect on progression. I have no financial disclosure and non-conflict of interest. So as we all know, COVID-19 pandemic since 2020 has put a huge impact on the general life and healthcare system, due to which multiple recurrent lockdown has been implemented in various parts of the country in multiple phases. For example, in first phase it was from March of 2020, and in second wave it was from March of 2021, in order to curb down the unprecedented spread of the virus and the resultant fatality. Travel restrictions and mass quarantine were implemented throughout the country, which hugely affected the treatment of chronic diseases like glaucoma. As we all know that even before the pandemic also, the adherence to anti-glaucoma medications and failure of periodic follow-up visits was an issue, and the pandemic had led to worsening of the situation. Now this study aimed at finding the factors that affect the compliance of anti-glaucoma medication, especially during the second wave of COVID-19 pandemic and the progression of the disease due to it. It was an observational cross-sectional study in the tertiary care hospital in the Cuttack district of Odisha from December 2021 to June of 2022. The inclusion criteria was we took patients of primary open-angle glaucoma who are on anti-glaucoma drugs and 18 years and older, and we excluded newly diagnosed cases of glaucoma, secondary glaucoma, primary angle closure glaucoma, history of glaucoma surgery, patients who were non-compliant before second wave of the COVID. So the methodology we used was the study was conducted in two parts. The first part consists of a questionnaire which included the demographic and clinical data of the patients, barriers for medication adherence during the pandemic, and the second part consists of examination like best corrected visual acuity using Snellen's chart, intraocular pressure reading using Goldman applanation tonometry, and visual fields by automated perimetry, and retinal nerve fiber layer thickness by OCT. The observation and results, the total number of patients we examined were 220 eyes of 220 patients, and the patients found to be non-compliant to anti-glaucoma medications were found to be 59.09%. Now coming to demographic details, most of the patients in our study were from the rural population, that is 58.18%, and more than 50 kilometers they have to travel to the hospital, 63.18%, and 67.72% belong to the lowest socioeconomic status, and 77.72% of patients were on more than 2 anti-glaucoma medications. Now the following were the barriers for compliance to medications during the COVID-19 pandemic. The 29.23% were due to financial difficulties, and followed by 24.61% longer distance to the hospital, 20.78% unavailability of the transport, and remaining were non-availability of the medications, caretaker non-availability affected by COVID-19, and family member illness. So now we actually compared the pre-second wave COVID-19 and the post-second COVID-19 variables using the paired sample t-test like best corrected visual acuity, intraocular pressure, RNFL thickness, and visual field index. And all were found to be statistically significant with a p-value of less than 0.001, as we can see in the screen. Now coming to discussion, in our study, 59.09% patients were found to be non-compliant to anti-glaucoma medications, whereas the study conducted by Subhadra G and et al. Showed a non-compliance of 57.3%, and Akan et al. With non-compliance of 28.4%, whereas the study which showed the highest non-compliance rate was by Rizwan et al., which is 80.5%. Now, the main reason for non-compliance to medication in our study was financial difficulties, that is 29.23%. But the studies conducted by Subhadra G et al., Somi et al., and Rizwan et al., they showed non-availability of the medications as the main barrier. In our study, 80.76% had raised IOP, 24.61% has decreased RNFL thickness, and 12.30% had reduced VFI than pre-COVID times as an effect of non-compliance. Whereas the study by Somi et al. Showed 81.25% with raised IOP and 78.13% with reduced VFI. So concluding the study, as we all know that COVID-19 pandemic had caused a statistically significant increase in the rate of non-compliance to glaucoma medication, principally due to lack of financial resources in our study, and this non-compliances has resulted in a statistically significant increase in intraocular pressure and decrease in best corrected visual acuity, retinal nerve fiber layer thickness, and visual field index compared with the pre-pandemic situation among patients presenting to our tertiary care facility. So we recommend that teleophthalmology should be the future to meet the need of the glaucoma patient, especially during pandemics. Thank you. This is the questionnaire, and thank you.
I know you're not part of the competitor section, but there are certain questions that arise from your presentation, excellent presentation, which, because we have time, we can talk about it. How do you think teleophthalmology helps in glaucoma?
Ma'am, in conditions when there is some epidemics or pandemics, when the people cannot visit the hospital, we can use teleophthalmology as a...
How do you do applanation, gonioscopy?
Yeah, ma'am, that.
So the only thing you can do is probably counsel patients that you have to continue with your medication.
The ongoing medication.
But the difficulty in glaucoma herein is that it is a progressive disease. So even if they don't discontinue, there is a likelihood that they can progress. There is a risk. So teleophthalmology, in my opinion, I refuse to do teleophthalmology. I'd rather just tell the patients continue with your medication than waste, You can't do applanation, you can't do gonioscopy, you cannot see the fundus, you can't see the disc. Anyone has any questions, any comments? We have time because I'm still alone. So, the other point that I thought is useful is that you said open angle glaucoma, you said primary open angle glaucoma, but you have a few patients below the age of 40. So they are actually juvenile open angle glaucoma.
No, ma'am, I excluded everyone from below the age of 40, ma'am.
No, you said 18.
Yes, ma'am. From 18
But
onwards,
you showed, there is a graph which shows a few patients.
Yes, ma'am.
So they are juvenile open angle.
Yes,
Believe me, juvenile open angle glaucomas will progress much more than primary open angle glaucomas.
Yes, ma'am.
Yeah. No one has any comments? Any views to share? You're all open? No? Okay. Thank you so much.
Thank you, ma'am.
Right, I've been told that we can actually start. I'll be the only one marking. So we start with Dr. Shalini Mohan. And she's going to talk to us about optic nerve sheath diameter in patients with glaucoma. Just make sure you can see the timer there.
Yeah. Good morning, respected judges and all the members present over here. I'm going to talk about optic nerve sheath diameter in glaucoma patients and its correlation with intraocular pressure. I don't have any financial disclosure. We know that optic nerve sheath is anatomical extension of the dura mater, and so that the subarachnoid space around the optic nerve is continuous with the intracranial subarachnoid space, and therefore CSF, which is surrounding the optic nerve, is in continuity with the rest of the central nervous system. So the lamina cribrosa at the bottom of the optic nerve head acts as a pressure barrier between intraocular space and retrobulbar space of the optic nerve. Therefore, any increase in the intraocular pressure, intracranial pressure, results into the volume increase in around these layers, and therefore there is increase in the optic nerve sheath diameter whenever there is raised intracranial pressure. Now, translamina cribrosa pressure difference is the difference between intraocular pressure and cerebrospinal fluid pressures. So diameter of optic nerve sheath within the eye is 1.6 millimeter, in the orbit is 3.5 millimeter, in the intracranial space is 4.5 millimeter. So any dilatation of optic nerve sheath has been shown to be an early manifestation of intracranial pressure rise. So it has been emphasized that CSF pressure might be associated with glaucomatous optic neuropathy. And we can actually measure the optic nerve sheath diameter by non-invasive methods like ultrasound, CT scan and MRI. So we did this study to study the optic nerve sheath diameter in patients of glaucoma, POAG, PACG and NTGs, and to correlate these parameters with intraocular pressure. This was a hospital-based cross-sectional study where patients were selected from glaucoma clinic of a tertiary care medical college. These were the inclusion criteria: patients who were newly diagnosed patients of POAG, PACG and NTG, and control subjects were also taken. And these were the exclusion criteria: any patient who was on anti-glaucoma medication or any other history of ocular trauma, eye surgery were excluded. Where detailed history and examination was done with regards to intraocular pressure, angle of anterior chamber, visual fields, disc photography, and then optic nerve sheath diameter measurement by ultrasound and by CT scan. So ONST was calculated perpendicular to the vertical axis of the scanning plane, 3 millimeter behind the globe, where the optic nerve is crossed by the artery, and the maximal changes are discernible at this particular point. So results, we had 38 POAG, 32 PACG, 18 NTGs and 48 controls. The mean age was almost equivalent in all the subjects except in NTG, which was slightly higher. Mean intraocular pressure was 27 in POAG, 49 in PACG, and NTG it was 16.72, and in control it was 15.19. The mean optic nerve sheath diameter was maximal in the patients of normal tensure glaucoma, which was 5.01 in comparison to all other patients, and it was similarly in CT scan group also it was maximal in NTG patients. So this was the plot showing the mean and the standard deviation in various groups, and this was the ONST diameter on CT scan in all the subset of patients. The correlation between optic nerve sheath diameter on ultrasound and CT scan was very good, and the significance was of 0.01 levels. The correlation between intraocular pressure and ONST was only seen in PACG patient, which was only mild correlation. So a discussion, optic nerve sheath diameter was significantly increased in NTG patients. Now this increased diameter raised intracranial pressures in the subset of patients, which is normal tension glaucoma. The compensatory increase in diameter leads to decreased flow pressure around the optic nerve, and because of the dilatation. And therefore, when we calculate this formula of translamina cribrosa pressure difference, that is intraocular pressure minus this gradient, there is raised TLCPD across the this lamina cribrosa, resulting into optic nerve head damage in normal tension glaucoma patient. So to conclude, I would say that ONSD measurement can be a useful tool for diagnosing NTG patient. If sheath diameter is more than 5 millimeter, that might be indicative of greater glaucomatous damage. TLCPD can be an important component of glaucomatous damage, and therefore analysis can help us to determine whether certain subset of patients are more likely to develop glaucoma or more likely to progress. Thank you so much for your kind attention.
Thank you very much, Shalini. That was great. I do have a few questions. The measurement was done in which B scan?
It was done in axial B scan, but in the transverse plane. So it was done 3 millimeter behind, and then it was measured with the in-bin calipers inside, and it was done by a radiologist, which was masked for all the patients, so that we can get the readings.
That was my second part of the question.
Okay.
Was the observer masked or not?
Yeah, definitely.
Right. So what you're trying to say is that it plays a role, TLCPD plays a role only in NTG, not in the other glaucomas?
Now, important thing is because in NTG we have normal intraocular pressures. So difference between, I mean, if TLCPD is raised, it will have more effect in these subset of patient. Once intraocular pressure is raised, TLCPD is automatically raised. So there the question is not very much important. It definitely plays a role over there also. But in NTG, because of this sheet dilatation, the relative pressure gradient reduces, and that is why TLCPD is relatively increased, and that is why. Yeah.
Okay, one last question.
Yeah.
So you never considered doing an LP for these patients?
Because it is an invasive modality and studies have proved
Thank you,
already.
thank you,
So much.
Yes, okay. The next Anand Naik bouquet. Okay, outcomes of bent needle ab interna goniectomy in severe primary open angle glaucoma.
Very good morning, one and all. I'm going with outcomes of bang goniectomy in severe glaucoma, moderate to severe glaucoma. No financial interest and no conflicts of interest. So, purpose is to assess the safety and efficacy of goniectomy in severe open angle glaucoma patients who are undergoing phacoemulsification in visually significant cataract. Methods, it's a prospective interventional study conducted at RP Center Ames, ethics clearance obtained, and POAG who are medically uncontrolled IOP with visually significant cataract were operated by single surgeon, that is Professor Tanuj Dada, in between November 2021 to December 2022. So this is the one small surgical clip showing we marked 30 degrees of marking with toric marker on the cornea, and we placed Swan-Jacob gonio lens, and through the gonio lens we injected indocyanine green dye to mark the trabecular meshwork, and we stripped 30 degrees of trabecular meshwork with bent 26 gauge needle, and after that we removed the strip of the goniectomy, and after that visco performed and tamponade done with air. Then this is the post-op, pre-op and post-operative ASOCT picture. This is the trabecular meshwork which is shown on swept source OCT, and this is the after goniectomy. This is the goniectomy cleft which is noted after around 3 to 6 months of period. So methods, we noted pre-operative and post-operative IOP, number of anti-glaucoma medications, gonioscopy, swept source spectralis ASOCT, and intraoperative complications were documented, and these patients are followed up at one day, 1 week, 3, 6 and 12 months post-operatively. So paid t-test was used to compare pre-operative and 12 months post-operative data, and p-value was considered less than 0.05 is considered significant. And we documented almost 46 eyes of 39 patients were operated for goniectomy with mean vertical cup dish ratio of 0.85 is to 1. So coming to results, the IOP, baseline IOP of the mean IOP is 28 mm of Hg, and pre-operative IOP after using of medications is reduced to around 18 mm of Hg. At post-operatively at 6 months and 12 months, it is 12.5 mm of Hg and around 12 mm of Hg respectively, with greater significantly decrease in IOP post-operatively. And the number of anti-glaucoma medications also significantly reduced from pre-operative to at 6 and 12 months post-operatively. So it is around 3.732, at 6 months it is 2.81, and at 12 months 2.82. That's the greater significantly reduced, around one medication reduction from pre to post-operatively. And more than 20% reduction in IOP was noted at 90% of eyes noted less than 20% of reduction in IOP. Less than 12 mm of Hg IOP reduction noted in around 83% of eyes, and more than one glaucoma medication droppage noted in around 66% of eyes. And zero medications required at 12 months and only 3 eyes, and filtration surgery required at 6 months in two eyes. And around 10 eyes within 1 week post-operatively we noted hyphema. After 1 week it resolved. And this is the one landmark study which is published by Dorairaj around 4 months before. That's KDB goniectomy with phacoemulsification. So they conducted study in moderate glaucomatous eyes. So we conducted study in advanced glaucomatous eyes. The IOP reduction is around 17.96 to 11, around 12 in our eyes. The mean change is minus 6 mm of Hg. And here in this study, the minus 4.4 mm of SG reduction was there. Percentage of IOP drop around 33.5% in our study and 26% in KDB study. Number of anti-glaucoma medications also reduced significantly, around 1 medication here and 0.8 medication in the KDB gonectomy study. So percentage of medication drop 24% in our study and 50% in the KDB study. So this mainly shows that post-operatively, post-operatively there is almost we increase the medication to bring the IOP to target levels. So that's why the medication drop was lesser in our study. So less than 20% reduction in IOP, around 90% in our study and 58% in KDB gonectomy study, and less than 1 decrease in anti-glaucoma medication, 75% in our study and 65%, around 65% in the KDB gonectomy study. Post-operative hyphema also noted very less in our study compared to gonectomy study. So coming to conclusion, 30 degrees gonectomy with 26 gauge needle is very safe and cost effective mix for the developing countries like India with favorable outcomes up to 1 year. So limitation of this study is very small sample size, needed more sample size for longer duration of follow-up also needed. So however, all these patients, majority of these patients required anti-glaucoma medication to maintain that low target IOP in severe primary open angle glaucomas. Thank you.
Thank you very much. That was a great presentation. I do have a few questions. I don't know whether I missed that or not. How did you decide the severity of glaucoma?
Severity glaucoma based on visual fields. So
What is the
first
criteria?
thing we done Humphreys visual field 24-2. If 24-2 is not means there is central constriction, then we go for 10-2. So
what do you mean by central constriction?
Center
Center is intact even in late glaucoma?
Yes, mostly in 0.5, 0.85. Some patients got total cupping also. In such patients, there will be in 24-2 around 25 degrees also involved. So in such patients, we perform 10-2. So in my presentation, I haven't mentioned mean deviation and visual field index. But as such, paper is coming up, so in paper we mentioned mean deviation, visual field index.
But I want to know what was the mean deviation, average mean deviation?
Average mean deviation is 11.95.
11.95 is
minus
not
11,
advanced.
11.
Is not advanced glaucoma.
So we consider more than 12 is
it
advanced.
will fall under.
More than minus 12 is considered advanced mean deviation, according to Anderson out of Paris Anderson criteria. So more than minus 12 consider advanced, along with some other factors. And visual field index also reduced around less than 45% in most of the patients.
Well, a minus 11 MD does not correlate with 45% VFI.
Yeah, there are some
average. I'm talking
there are
about
some
average.
visual fields of patients got that Goldman visual field also.
Okay.
So that's why in Goldman visual field patients we considered as some that previous visual field mean deviation we take enough.
Okay. Do you think that doing slightly more than 30 degrees would have resulted in greater reduction of anti-glaucoma medication?
Yeah, we did in around 10 patients, like 30 versus 45 degrees. We did the goniectomy around 30 versus 45 degrees we did, but in some patients 60 degrees also we did.
Okay.
But there is no major change we grossly identified like IOP reduction or anti-glaucoma medication reduction. So basically stick to that very minimal degree of manipulation of the trabecular meshwork.
Okay, thank you very much.
Yes.
Call the next speaker, Dr. Riddhima Juneja. She's going to talk about topical ripacidil, 0.4% versus topical nitarcidil, 0.02% in patients of primary open-angle glaucoma.
Good morning, all. My study is, as ma'am said, a prospective study to compare the intraocular pressure lowering effect of topical ripacidil 0.4% and topical nitacidil 0.02% in patients with primary open-angle glaucoma. There are no financial disclosures of conflicts of interest to declare. As we all know, the problem statement, glaucoma is currently the second leading cause of blindness worldwide, however, is preventable. And early identification and timely intervention can prevent this. Rho kinase inhibitors or ROC inhibitors are the newer classification of drugs for treatment of primary open-angle glaucoma as well as ocular hypertension that have been shown in preclinical studies to lower the intraocular pressure by extracellular matrix remodeling of the trabecular meshwork, especially the juxtacanalicular system. Additionally, we see that nitacidil has a different mechanism of action as compared to ripacidil. That is why my study became a little more interesting. The aim of my study was to see the effective intraocular pressure lowering between the two and compare their side effect profiles. The lacuna in existing knowledge is that there are very few studies comparing the two things along with their side effect profiles. And to my knowledge, no Indian study on Indian population has been published as for now. My study design was a randomized control trial done in a tertiary care center in northern India on 140 eyes, selected from patients attending the Department of Ophthalmology, meeting the criteria for primary open-angle glaucoma. They were randomly distributed into two groups, Group A and Group B. Group A receiving 0.02% nitacidil and Group B receiving 0.4% twice daily ripacidil. On the first visit, consent was taken and baseline investigations were monitored, and office hour fluctuation of intraocular pressure taken at 9 a.m., 11 a.m., 1 p.m. and 4 p.m. The visits were done subsequently on 3 weeks and 3 months, and the patients were reassessed to measure diurnal variation of intraocular pressure along with the other baseline parameters. The side effect profiles were therefore as well followed up on. My inclusion criteria were all individuals above the age of 35 years diagnosed to have primary open-angle glaucoma with best corrected visual acuity of 624 or more, intraocular pressure more than 20 and less than 34 mmHg with a CD ratio of less than or equal to 0.8, and early to moderate visual field changes according to the Huda-Parrish-Anderson-Padella criteria. These were some of the exclusion criteria. No children, no pregnant or lactating women were involved. Any local abnormality that would hinder in doing a Goldman applanation tonometry were also excluded out of the study. Also, individuals having severe forms of glaucoma were excluded. My statistical analysis was done with an SPSS software version 25 with a p-value of less than 0.05 taken to be statistically significant. Coming to my results, according to the age distribution, there was no significant difference in age in both the groups. The ripacidil group, however, we saw after 3 months, intraocular pressure lowering came to about 3.48%, and for nitacidil group, the IOP lowering was 5.71%, both of which was statistically significant. Hence, the average IOP was significantly lower with topical nitacidil as compared with topical ripacidil at the end of 3 months. We also looked for the adverse events in ripacidil and nitacidil groups at 3 months. The most common adverse event noted was eye irritation, which was checked on the visual analog scale, and conjunctival hemorrhage. We found that with the ripacidil group, 44.3% actually had adverse events noted, whereas with the nitacidil group, there were 32.9% of the adverse events noted. These are some of my references, and thank you.
In the inclusion group, you had in the study group visual acuity better than 6/24. Any specific reason why did you do that?
Sir, so that visual fields could be analyzed as a standard for all individuals. People who have worse vision as from 6/24 would not be able to do the visual fields as accurately as individuals with a better visual field.
But
and also because the individual, I wanted to perform a 24-2 and a 30-2 as a baseline visual field.
But none of your slides mentioned anything about the visual fields. Only criteria which you showed was, one was efficacy as far as IOP is concerned and the side effect profile.
Yes, sir.
So visual field was not included.
No,
as
sir. I included the Huda-Parrish Anderson criteria. And the last point with visual field changes.
Right, I have a question for you. The efficacy you got in both the groups.
Yes.
Do you think that's acceptable as a single anti-glaucoma agent?
That's not acceptable, ma'am, because if we do not give them a prostaglandin analog as our first line of management and as monotherapy, it would be negligence on our part. Hence, we did a study for 3 months, which was a shorter duration, and just to see how the effect was as monotherapy. And as add-on therapy, the drug is already prevalent and people are using it.
I mean, that point is taken, but
Yes, sir.
what do you think is an acceptable percentage of IOP reduction with any one agent?
At least 15 to 20%, ma'am.
Great, thank you.
Invite the next speaker. Next speaker is Dr. Kajal Priya, and the title is Comparison of Angle Parameters in Normal, PACD and POAG by Pentacam and Correlation with Gonioscopy.
Good morning, everyone. Now I'm going to present my topic, no financial interest. My topic is comparison of the angle parameters in normal PACD and POAG by Pentacam and correlation with the gonioscopy. As we know that glaucoma is the leading cause of irreversible blindness and second leading cause of blindness. Prevalence of primary open is 3.54 and prevalence of the PACG is approximately 0.92%. In contrast of higher prevalence of primary open angle glaucoma, primary angle closure has a 3-fold greater risk of developing blindness compared to primary open angle glaucoma. Gonioscopy is a gold standard, but it's a subjective evaluation method, so intra-observer reproducibility is poor, associated with risk of contamination, and patient cooperation is much more required. Pentacam is based on the symbolic principle, generate precise, sharp, and anterior chamber, allowing for quantitative measurement of the topography, thickness, and anterior morphometric value in a few seconds. This non-contact, contamination-free skill examiner is not required, and minimal patient cooperation is required. Now my aim is assessment and comparison of the angle structures and quantitative angle parameter by using Pentacam and gonioscopy in normal, POAG and PACD, and to draw a reference range of angle parameter to identify narrow angle by Pentacam at a tertiary eye care center in southern India. It was hospital-based prospective observational study done in Sankara Eye Hospital. Duration is 1 year. Normal subjects, POAG and PACD, more than 20 years are included in my study. Open angle, secondary angle closure, any intraocular disease or surgery, age less than 20 years is excluded in my study. All patients underwent for ethical written informed consent. Total 123 patients are included in my study. In gonioscopy, they are divided into surface grading. Statistical descriptive analysis was carried out by the mean standard deviation for quantitative variable, frequency and proportion for category variables. ACDC, and angle P in predicting angle closure was assessed by the receiver operative curve analysis, and P less than 0.05 considered statistically significant. My mean age is 55.47 plus minus 9.84. Female to male ratio is 1.6:1. In my study, approx 70% has better visual acuity, more than 612. The angle G mean is 16.99, ACD volume 106.91, ACDC 2.37, and angle P 30.67 degree. When we classify all value in surface grading, then we got statistically significant difference. But in grade 2, we have less value than grade 1 because we have less patient in grade 2. Out of total 50% angle closure and approx 50% we have primary open and normal, that is open angle. When we compare angle closure to open angle, we got a statistically significant difference in on value. We got cutoff value for ACD volume is 106 millimeter after ROC analysis. So sensitivity of this test is 84.68 we got, and specificity of this test 84.43. and diagnostic accuracy of this test we got 84.55%. The same ROC analysis we got cutoff value of ACD is 2.40 millimeter, and sensitivity is 90%, 90.32%, specificity is 88.52%, and diagnostic accuracy is approx 90%. The angle we got the cutoff value 30.45 degree. Specificity and sensitivity is lesser than the ACDs and ACV volume, and diagnostic accuracy was also approx 76%. So according to discussion, Alonso also took 2.6 millimeter ACD cutoff value, but they told 100% accuracy, has sensitivity. But in my study, we got 90%. Maybe we have more patients. Castillo took all data and they told that ACDC has a good sensitivity to diagnose the angle closure. So we got the same limitation. It cost, pentacam was costly, not able to see angle pathology like foreign body NBA pigments. So conclusion, gonioscopy remained the gold standard, but intra-observer reproducibility is poor. Pentacam values such as ACV and CSCD is good predictive value, and especially in uncooperative patient. Angle P has also predictive value, good predictive value, but lesser than ACV and ACDC. So pentacam we can use as a practice for non-contact mask screening method. It is also advantage for the patient and examiner, particularly in this pandemic area, and also helps in the refractive surgery. Thank you. These are my reference. Thank you.
So the point remains that you can still have false positives and false negatives on any objective device. So what would be your conclusion? You would train in gonioscopy or not?
Obviously, ma'am, gonioscopy is a gold standard. We can't eliminate. But for mass screening process, we can use a cutoff value. So we separate that patients too, and we can do on that patient only gonioscopy.
See, like you have mentioned, three parameters: central anterior chamber depth,
ACV,
anterior chamber volume, and the angle also. So, will you take for selecting these patients? Will you take combination of all these three factors, or just one factor, like ACD less than 2.4 or anterior chamber volume less than 106? Because just one parameter may have, like Madam said, a lot of false positives. All hypermetropes may have ACD less than, many of the hypermetropes may have ACD less than 2.4. So that means you'll do everything or just combination of these three factors?
Oh, I just comparison of these three factors, sir. All three factors should include.
So gonioscopy, according to you, still remains the gold standard?
Yes.
Okay.
Rita? She's going to talk about changes in visual outcome, IOP, and astigmatism in patients undergoing combined surgery.
Good morning, one and all. I'm Dr. Harita. Today I'm going to speak on a comparative study of changes in visual outcome, intraocular pressure, and astigmatism in patients undergoing combined surgery. There are no financial interest to disclose in this study. Coming to introduction, intraocular pressure being the main modifiable risk factor in treating glaucoma. So lowering intraocular pressure helps to arrest or delay progressive optic neuropathy, and this prevents irreversible visual field loss. And cataract being the leading cause of outward blindness worldwide, studies have shown that postoperative intraocular pressure could be lower when cataract surgery was combined with trabeculectomy. The main aim of the study is to compare changes in intraocular pressure and visual parameters in patients undergoing phacoemulsification with trabeculectomy with small incision cataract surgery combined with trabeculectomy. Main objective of the study is to compare changes in visual outcome, intraocular pressure, and astigmatism both preoperatively and postoperatively in phacoemulsification with trabeculectomy versus SICS with trabeculectomy. Coming to materials and methods, this is an observational study using convenient sampling. I have taken 40 patients with cataract and coexisting glaucoma and divided into two groups. Group A patients into 20 who have undergone SICS with trabeculectomy, and group B 20 patients who have undergone phacoemulsification with trabeculectomy. The study was done for a duration of 6 months, and the study tools used were Snellen's visual acuity chart, Goldman applanation tonometry, and automated refractokeratometer. Informed consent and ethical committee clearance was taken. Coming to inclusion criteria, patients with age 40 years and above were included. Patients who are having visually significant cataract according to LOCS 3 grading were considered, and patients with coexisting primary open angle glaucoma based on Humphrey field analysis mean deviation score, moderate and severe glaucoma were considered in this study. Coming to exclusion criteria, patients with secondary glaucomas were excluded, and patients with any other ocular trauma or previous surgeries were excluded. Coming to methodology, all the patients underwent preoperative and postoperative evaluation for visual acuity, keratometry for corneal curvature readings, Goldman ablation torometry for measuring intraocular pressure, and 30-2 Humphrey visual field analysis was done. And comprehensive posterior segment examination was done in all the patients. All the surgeries were performed by a single surgeon, and the incision site was superior for SICS with trabeculectomy and superior temporal for phacoemulsification with trabeculectomy, and patients were followed up after 1.5 months. Coming to statistical analysis, the data in the two groups were compared preoperatively and postoperatively using pair t-test, and between the two groups it was compared using independent sample t-test. Surgical induced astigmatism was calculated using SIS software, and the data was analyzed using Microsoft Excel datasheet. P-value less than 0.05 was considered statistically significant. Coming to results, comparison for changes in uncorrected visual acuity, best corrected visual acuity, and intraocular pressure preoperatively and postoperatively in the individual groups were compared, and they showed there is statistically significant difference preoperatively and postoperatively in all the parameters in the individual groups. While comparing surgical induced astigmatism in SICS trap and phaco trap, there was no statistically much significant difference between the two surgeries. Comparing visual acuity and intraocular pressure between the two surgeries, there was no much statistical significant difference between the two surgeries. Coming to discussion, in my present study, it was considered that combined procedure has showed better visual outcome, better control of intraocular pressure, and fewer complications in patients with coexisting glaucoma and cataract. Similar studies where in one study they have compared phacoemulsification versus phacoemulsification with trabeculectomy in primary angle closure glaucoma patients. In a study of 79 patients, it was shown that phacoemulsification combined with trabeculectomy is more effective in reducing intraocular pressure and lessens the need of glaucoma drugs when compared to phacoemulsification alone. And another study with which has compared phacotrabeculectomy with small incision cataract surgery has shown there is no statistically significant difference in the final visual outcome and intraocular pressure and postoperative complication rate between the two groups, similar to my study. Coming to limitations of the study, in this study I've included only patients with primary open angle glaucoma, and patients with mild glaucoma were excluded. A longitudinal follow-up over a period of 6 months to 1 year is needed to study the comparison effectively between the two procedures. Coming to conclusion, combined procedure, it showed better visual outcome, better control of intraocular pressure, and fewer complications in patients with glaucoma and cataract in both the groups. As the combined procedure helps in handling the two morbidities in a single setting, this reduces the need for glaucoma medications, frequent follow-ups, and also blends post-operative IOP spikes following cataract surgery. These are my references. Thank you.
What was the type of incision used for SICS in the combined surgery? You didn't mention about that, because that will really be making a lot of impact on type of
corneoscleral incision.
No, corneoscleral what? Straight, frown, or Blumenthal type?
It was a frown incision.
So you should mention that. No?
Sure.
But you did not find any difference in the SIA between this combined
Not
SICS trap?
statistically significant, sir. The difference was there, but not statistically significant, sir. P-value was There was a difference between the two in SIA, sir. In SICS group, the mean was 1.35, and in FACO group, it was 1.073, but this was not statistically significant.
It is rather unusual, but do you think that, sorry, I am confused about one thing. You followed it up for 6 weeks or 6 months?
6 weeks, ma'am.
6 weeks is too short a period. Do you think bleb remodels over a period of time and can cause changes in astigmatism?
Yes, ma'am. That's why I've mentioned that it needs longer duration to compare procedures.
So then, do you think your results are valid?
Not.
Okay, at least you're honest.
Thank you.
The next speaker, Dr. Kavya Nazneen. She's title of presentation is Red Eye After Netarsudil.
Good morning to all. My study topic is side effects after nitazoxanide. There is no financial disclosure and no conflicts of interest. Glaucoma is chronic progressive optic neuropathy which leads to characteristic irreversible visual field defect. High IOP is the major risk factor. Glaucoma affects approximately 76 million people worldwide and can be increased to 112 million in 2040. Its leading cause of irreversible blindness. Nitazoxanide is a ROC kinase inhibitor. It decreases the IOP by affecting the aqueous dynamics in 3 different ways, increasing the tubercular outflow, decreasing episcleral venous pressure, and reducing aqueous humor production. FDA approved nitazoxanide solution 0.02% in December 2017 in primary open-angle glaucoma and ocular hypertension. For patients who require more vigorous IOP control, nitazoxanide can be used. This study aimed to find out the side effects of nitazoxanide and how it affects the course of anti-glaucoma treatment. It's a prospective study in a tertiary care hospital in eastern India from August 2022 to February 23. The patients of primary open-angle glaucoma or ocular hypertension above 18 years or older are included in the study. Non-hypersensitive to other anti-glaucoma drugs, patients of intraocular surgery or trauma, primary angle closure and secondary glaucomas, patients not willing to give consent and follow-up, non-case of ocular surface disorder, pregnancy and lactating patients were excluded. The patients, the demographic and clinical data, duration of glaucoma, duration and frequency of nitazoxanide, any new side effects developed after nitazoxanide use, any history of discontinuation of nitazoxanide or change of nitazoxanide, other glaucoma drugs were collected. These patients were evaluated at BCVA, slit lamp, IOP reading with Goldman ablation tonometer, fundoscopy, gonioscopy, visual fields, central cornea thickness and RNFL thickness. 70 patients were examined and given nitazoxanide eye drop fulfilling inclusion and exclusion criteria. Out of 70 patients, 66 patients continued the treatment for 7 months. Out of that, 34 continued without any side effect and 32 continued with some sort of mild side effect. Around 4 patients discontinued the treatment in our study. Out of that, 3 discontinued due to some sort of side effect. The variables such as IOP, BCVA, RNFL thickness and visual field were calculated pre-nitazoxanide and 6 months post-nitazoxanide and p-value is calculated. Out of 70 patients, 37 patients developed conjunctival hyperemia followed by lacrimation followed by blurred vision. 47 patients has more than one adverse side effect. Out of that, mainly it is ocular side effect. No systemic side effect, serious side effect and death were found in our study. Out of conjunctival hyperemia, 29 patients have grade 1 hyperemia according to the Mandel's slit lamp classification system of conjunctival hyperemia. Most of the patients develop hyperemia between 1 hour to 1 week after the installation of the drop. Our study found out that 50% of developed adverse effect in which 45% continued study and 4% discontinued the study due to adverse effect. Conjunctival hyperemia is most common adverse effect followed by lacrimation and followed by blurred vision. 41% of hyperemia is grade 1, mostly seen between day 1 and day 2 after day 1 and 1 week after instillation of the nitrosodil eye drops and resolved by continuous use. 67% have more than one side adverse effect, mainly ocular effect. No systemic adverse effect were found. ROC1 and ROC2 trial shows that incidence of adverse effect is 50 to 53%. Most frequently reported conjunctival hyperemia, which is 61%. 28% discontinued the study discontinued due to some sort of side adverse effect. Severity is mostly mildly onset. It's little bit early onset, 50 to 60% within first 24 days of study. Lewis et al. Study reported that greater number of discontinuation taking nitrosodil are due to the conjunctival hyperemia. Surley et al. Suggested that once daily dose will decrease the symptoms during waking hours. Investigative ophthalmology and visual science reported that conjunctival hyperemia is common side effect at months 1 and 3, blurred vision, followed by blurred vision. Bakarki et al. Study shows that conjunctival hyperemia is seen in 57%. The hyperemia fades with time. We concluded that nitrosodil has significant reduction in IOP so that it can be used as an adjunct to other anti-glaucoma drugs. It has notable side effects such as conjunctival hyperemia, mostly mild grade. It can be managed once daily administration and it fades with intensity with time. Thank you.
Yeah. Your patients were put only on nitrosodil or they were also?
Nitrosodil we use as an adjuvant to the some other anti-glaucoma, especially prostaglandin analogs we use.
What other anti-glaucoma medications were they using?
They are mainly using prostaglandin analogs. We use nitrosodil as an adjuvant in the patient, those who are not attaining target IOP. Even after that, we as an add-on we given nitrosodil.
So if the patients were already on other drugs like prostaglandin analogs or alpha agonists, they can also induce hyperemia. How do you ensure that this hyperemia?
That we are excluded. That patients we are excluded. In exclusion criteria, the patients non-case of hypersensitivity to any anti-glaucoma drugs we are excluded. But still there can be. That is.
Sir,
Can be.
excuse me.
Sir, we are glad to know that, but this is free papers and audience interaction is not. Yeah, okay. So, how long was the study?
For 7 months. Actually, 6 months we evaluated and 1 month for 5 days.
And you actually found that the severity of hyperemia came down?
Came down with continuous use. But some patient, 4 patients refused to the only grade 1 mild degree of hyperemia is noted.
And the reduction of IOP that you are showing is with pre was with the prostaglandin analog?
With
prostaglandin.
Before adding nitrosodil and
So
after.
Then you seem to have got a fair amount of reduction of IOP.
Mean IOP is almost 3.
Okay. This is contradicting a previous study. Thank you. Oh, wow. I call upon Dr. M. V.L. Narasimha Rao. Here? Yes. We please start.
A very good morning to respected one and all. I am going to talk about the interplay of antihypertensive medications, ocular perfusion pressure, and glaucoma progression. There are no financial interests or relations to disclose as a part of this study. And coming to introduction, we all know glaucoma is a chronic progressive optic neuropathy characterized by RGC death and associated visual loss. Among different vascular factors associated with glaucoma, blood pressure is the most studied factor because it is related to both microvascular blood flow and also to the IOP, because these two main elements determine the ocular perfusion pressure. And there is a bimodal relationship which was established recently between blood pressure and the risk of glaucoma, indicating that either the patients which are having either high BP or low BP have risk of developing or progressing of glaucoma, because in the patients with systemic hypertension and glaucoma, vascular dysfunction does not allow the activation of autoregulatory mechanisms. So this will lead to decrease in IOP even though there is increase or decrease in blood pressure. Several markers may be used to assess the risk of glaucoma. Among that, we have studied about the ocular perfusion pressure, which is a potential marker of ONH perfusion and major culprit in causing and progressing glaucoma. The aim of the study is to evaluate the relationship between the antihypertensive medication and the progress of glaucoma. And my objectives are I will assess the effect of antihypertensive medication at bedtime on systolic, diastolic and ocular perfusion pressures, and these pressures associated with the progression of glaucoma. And this is a type of analytical observational study done for 6 months in the tertiary care center in Andhra Pradesh. There is a specific inclusion criteria for this study. I have taken the patients who are a known case of primary open angle glaucoma associated with primary systemic hypertension, and they are using both the anti-glaucoma medications and antihypertensive medication at bedtime for at least 1 year. And all these patients were assessed by single observer, and these patients were we have took 45 glaucoma patients. These patients were divided into 3 groups based on ICD-10 guidelines into early, moderate and advanced glaucoma. And we have excluded the patients who are not on bedtime antihypertensive medication, and the patients who are not on regular anti-glaucoma therapy, and the patients who already underwent surgical glaucoma management, and the secondary glaucomas and secondary hypertensions are excluded from this study. And we have done assessment of best corrected visual acuity, anterior segment examination, then followed by IOP by Goldman applanation tonometry. We have done 24-dashed Humphrey visual fields for every patient, and 4-mirror indirect contact gonioscopy was done. And after that, we have done dilated fundus examination. And after 5-minute period of rest, we have measured supine position blood pressure, which we took 2 recordings and make an average of that, and we calculated mean ocular perfusion pressure using the formula, which is 2/3 of mean arterial pressure less than intraocular pressure. So mean arterial pressure is diastolic blood pressure plus 1/3 of pulse pressure, and systolic perfusion pressure and diastolic perfusion pressure are calculated by the formulas. And we have obtained the significance by using ANOVA single factor test. In all those statistically tests, we took the p-value which is less than 0.05 to be significant. And as the patients are medically controlled IOP, there is no significant mean difference between the 3 glaucoma groups in IOP, but whereas ocular perfusion pressure in advanced glaucoma is around 50 mmHg, and whereas in early glaucoma it is around 60 mmHg, and there is statistically significant difference among these 3 groups. And similarly with that of diastolic perfusion pressure, there is significant statistically significant difference among these 3 groups. Similar to that of systolic perfusion pressure also, there is a mean difference which is statistically significant among the early, moderate and advanced glaucoma groups. And coming to discussion, the study ascertains the patients who are on rigorous antihypertensive treatment are due to nocturnal hypotension. These patients have low perfusion pressures and they are increased at progression of glaucoma. There are some other studies which have showed the similar relation, and there are 2 studies which were done by Kim et al. And Rekha Kandalwal et al. Inferred that lower mean ocular perfusion pressure was shown in the patients with open angle glaucoma when compared with controls, and the Baltimore Eye study showed a stronger association between diastolic perfusion pressure less than 50 mmHg with the development of glaucoma. And similarly, the Singapore Malay Eye study also reported the low diastolic perfusion and low diastolic blood pressure and low mean ocular perfusion pressure are the independent risk factors for open angle glaucoma. And there are other similar studies which shows the open angle glaucoma risk with diastolic perfusion pressure less than 50 mmHg. Similarly, Los Angeles Latino study was show increased prevalence of open angle glaucoma with lower mean ocular pressure. And from these studies, it is understood that people that on antihypertensive medication have increased risk of developing progressing of glaucoma. And the main limitations of the study are the blood pressure and IOP measurements were performed only once during daytime. and there is no 24-hour blood pressure monitoring and no 24-hour IOP recording. So this was the main limitation of the study, and the single IOP measurement can miss the IOP peak and IOP fluctuations, and direct measurement of ocular blood flow by velocimetry and speckle flow flowmetry and all these things have more usual assessment of and more accurately assessing the ocular blood flow when compared to that of we are using only a theoretical formula by calculating the blood pressure, intraocular pressure. Maybe direct methods of knowing the perfusion pressure ocular blood flow was more valuable in this case studies, and my study concluded that lower blood pressure, lower perfusion pressure are having more higher risk of progression of glaucoma. So perfusion pressures can be potential screening tools to identify the patients on overdosage, and we can decrease the rigorous antihypertensive treatment to avoid night dosage in patients with nocturnal dippings. These are my references. Thank you.
So to increase the perfusion pressure, what can be done? One is decrease intraocular pressure, and second is increase blood pressure. So you should stop antihypertensive treatment in these patients?
No, sir. But we can avoid nighttime. But we can avoid nighttime antihypertensive therapy in these patients. So we can prevent the nocturnal dipping of blood pressure. So prevent systemic hypotension. So we will decrease the.
So did you evaluate any specific type of antihypertensive treatment which cause less of postural and nocturnal hypotension? Like?
No, sir. These patients are generally, usually these patients are all using clinidipine and amlodipine. So these patients are using calcium channel blockers mainly. So I haven't compared any among different types of
there's difference between this hypotension between calcium channel blockers and the beta blockers. So you could have evaluated that, right?
Thank you very much.
Can we have the next speaker? Dr. Maleswari Medikonda. She's going to present her paper on retrospective review of cataract surgery outcomes in patients with nanophthalmos. Achha, sorry. Dr. Vishnu Priya Narasannagari.
Good morning and all. My study title is a retrospective review of cataract surgery outcomes in patients with nanophthalmos. Nanophthalmos is a rare genetic disease with a small eye secondary to compromised growth. It is characterized by short axial length, high lens by eye volume ratio with narrow angle, high hyperopia and scleral thickening. A sudden decompression of the globe following any kind of surgery may result in rapidly progressing choroidal effusion and suprachoroidal hemorrhage. So some authors will consider to perform forced sclerostomy before opening the eye. Our aim of the study, the cataract surgery outcomes in patients with nanophthalmos in tertiary eye care hospital respectively. Materials and method, we included patient age more than 20 years with axial length less than 19.6 millimeter, and we excluded age less than 20 years and with axial length more than 19.6 millimeter. It is a retrospective study. We included 25 patients, that is 46 eyes with nanophthalmos, and study period is 8.5 years. We included, we measured visual acuity, intraocular pressure, pre-peripheral iridotomy and post-peripheral iridotomy, cataract surgery data, intro-op, post-op complications, and post-op visual acuity. The patients were taken up for surgery only after controlling the intraocular pressure by doing prophylactic ACT peripheral iridotomy and by giving adequate intraocular pressure lowering agents. And the results were, out of 25 patients, the mean age was 54.44 years, and the gender distribution, females are 19 were females and 6 were males. Out of 25 patients, 3 patients are nanophthalmos associated retinitis pigmentosa and consecutive optic atrophy. And 21 patients were bilateral and 4 were unilateral. And the mean axial length were 18.36 millimeter. IOL power ranged from 30 diopters to 44.5 diopters with a mean of 40.5 diopters. And out of 25 patients, 8 patients underwent peripheral iridotomy and 7 patients have not underwent peripheral iridotomy. Most of the patients were within 10 to 20 millimeter of mercury. Out of 25 patients, 18 patients underwent cataract surgery. In this, both eyes patients were 9 patients and one eye patients were 9 patients. All the patients pre-op intraocular pressure was normal, and the 7 patients out of
18 patient, one patient intraocular pressure was 60 millimeter of mercury preoperatively. So IOP was controlled with topical and oral anti-glaucoma medications and IV mantle 1 hour before surgery. And the surgery was uneventful. Post-op visual acuity, in 11 patients there was no drop in the visual acuity, and 16 eyes there was improvement in the pre-op visual acuity. Coming to discussion, nanophthalmus is a rare clinical spectrum of disorders with phenotypically small but morphologically small eyes. Cataract surgery in nanophthalmic eyes is often challenging with poor visual outcome and potential complications such as uveal effusion, retinal detachment, and corneal decomposition. These are more prone to develop uveal effusion either from thickening of sclera and reduced scleral permeability to protein, or from dense collagen around the vertex wings resulting compression of venous drainage channels. In the present study, we had done phacoemulsification with IOL implantation in 18 patients. The surgery was done after controlling the intraocular pressure adequately, and we had done cataract surgery without doing sclerostomy. None of the patients had any uveal effusion intraoperatively or postoperatively. Similar to the study done by Fosher et al., all the sclerostomy was not performed. Prior to phacoemulsification, none of the patients landed in uveal effusion. In a study done by Sharmila Rajendra Babu et al., they had done cataract surgery with sclerostomy and without sclerostomy, out of which 3.33% patient had uveal effusion as a complication in cases with sclerotomy, and 12.76% patient had uveal effusion in cases without sclerostomy. In another study done by Sharmila Rajendra Babu et al., 12.9% patient who underwent cataract surgery without sclerostomy had uveal effusion as a complication, but none of the patients in sclerostomy group had uveal effusion. So I conclude none of the patients had any intraoperative postoperative uveal effusion. By controlling intraocular pressure prior to the surgery by either giving oral glycerol or IV mannitol and by doing yak peripherectomy when required, complications like choroidal effusion, suprachoroidal hemorrhage can be avoided without doing sclerostomy prior to the opening the eye. These are my references.
In some of the patients in both the groups, you had not done peripheral iridotomy. Still, they did not present with uveal effusion. So how do you explain that? What measures did you take in those patients? You said measures, if you want to avoid sclerotomy, then you have to take those measures like peripheral iridotomy or conservative measures like mannitol, etc. But in some of the, I think almost half of the patients, you did not do peripheral iridotomy.
For that patient, before going surgery, we have given oral glycerol, sir.
Oral glycerol was given in all the patients with PI or without PI,
yes,
right?
Sir. Yes, sir.
So, which was more effective then? That means PI or conservative measures or combination of, how do you cannot have conclusion like that. Then,
PI was effective in the eyes more prone to angle closure. I mean, in nanophthalmus, all eyes are not prone to angle closure. In some eyes, it is open angles also. No.
Yeah, I agree with that. But there was none of the eyes that required any glaucoma procedure?
Our sample size is very less, ma'am. So
okay, thank you.
Speaker is Dr. Chitra Arasada, study on short-term effect of 2% pilocarpine on IOP before laser peripheral iridotomy.
Good morning everyone, I am Dr. Chitra. This is a study on short-term effect of 2% pilocarpine on intraocular pressure before laser peripheral iridotomy. I have no financial disclosures. Primary angle closure glaucoma is a visually more destructive form of the disease, and the blindness due to angle closure glaucoma is devastating. Laser peripheral iridotomy is a treatment of choice in angle closure disease. Pilocarpine eye drops are used in short-term management to prepare the eyes before laser to induce miosis and to stretch the pupil. Study shows that topical pilocarpine reduces intraocular pressure in an hour, and the effect lasts for 48 hours and with the IOP lowering effect of 20 to 25% on long-term usage. The aim of this study is to study the short-term IOP changes after pilocarpine instillation and before laser peripheral iridotomy. The study is done in Geetham Hospital. It's a hospital-based interventional study done over a period of 6 months on 60 eyes of 30 patients with angle closure disease. Patients with diagnosed angle closure disease on gonioscopy were included in the study, and contraindications for pilocarpine use like uveitic glaucoma, neovascular glaucomas, phacolytic glaucomas were excluded. Any contraindications for laser were excluded. Pilocarpine allergy were excluded in the study. All the patients underwent a careful slit lamp examination, visual acuity is noted, applanation tonometry is done, gonioscopy is done, baseline intraocular pressure before instilling 2% pilocarpine is noted, and subsequently the sequential intraocular pressure readings were noted for every 15 minutes and the percentage of IOP reduction is calculated. This is the case sheet pro forma showing history and anterior segment examination. Applanation tonometry readings were recorded and gonioscopy is done. Coming to the results, the gender distribution of the disease, it is a female preponderant study with 77% of cases being females. Age distribution, the prevalence of the disease increased with increasing age with almost 56.6% of the cases belonging to age group of 61 to 70 years. Risk factors, hyperopia was found to be the chief risk factor, followed by diabetes, hypertension, followed by anxiety and family history. The mean of intraocular pressure values before administering pilocarpine was found to be 18.1 with a standard deviation of 7.82. The mean values of intraocular pressure after administering pilocarpine was found to be 14.8 with a standard deviation of 6.39. So there is a significant difference in the reduction of mean IOP values before and after pilocarpine administration with a p-value of 0.001 which is significant on paid sample t-test. Primary angle closure glaucoma is a vision threatening condition and it needs urgent LPI. Laser facility may not be available everywhere and sustainedly raised intraocular pressure can lead to a painful blind eye. Pilocarpine is used to facilitate the eye before laser procedure. In this study, we have noticed the short-acting effect of pilocarpine on intraocular pressure before doing the laser procedure. A significant reduction in intraocular pressure is noted. This is in accordance with the Yunard A. et al. Study who showed a significant reduction in IOP post-pilocarpine use with a p-value of 0.002. In conclusion, topical pilocarpine instillation can significantly reduce the intraocular pressure and thereby can delay the adverse effects of angle closure crisis. This therapeutic property of pilocarpine can be used in glaucoma whenever necessary, provided there are no contraindications for its use. The drug can be handy in conditions where LPI have to be delayed or in facilities where laser facility is not available, and it can be a savior of vision in cases of delayed laser intervention. These are my references. Thank you.
Thank you very much. So, you did or you instilled pilocarpine prior to laser on the day of laser?
Yes, ma'am.
Or were the patients already on
No, ma'am.
pilocarpine before?
No, ma'am. On the day of laser itself, we have
How long before the procedure?
1 hour before the procedure, ma'am, for every 15 minutes.
Right. Okay. Thank you. Now Venkatesh Ramesh, who is going to talk about innovative, self-built, 3D, cost-effective smartphone application for simulative mixed learning. Mouthful.
Thank you for the opportunity, AOS. So I'm going to take you into a world of simulation and how we validated it. So I got this idea when I was doing an eye stent inject here, as you can see. The first stent was under-implanted and it just fell off. And then the second stent, I had to just make sure I gave it a much better dimple. And once they implanted the second stent first, and this is me taking the first stent that it was under-implanted. And when I came out, actually I didn't fail to close the trocar. So I again lost it in the corneal wound. So I was able to then retrieve it and then go back in. So this is one of the learning scenarios where you may drop your stent or it may get caught into the corneal wound. So I just went back to my drawing board, and this is the hologram headset that we have actually generated in our lab. You can see on the right hand side here, my friend is actually moving through thin space. So he's actually moving his hands, and we went back and we thought, can we really make a simulator for portable learning? We do have many wet labs. In Godsey, it's not really possible, but then you can see him, this is him using this headset and he's able to place it. So we thought, can we validate it so that it will help in hand-eye coordination, because for eye stent injects 1, generation 1 there is a tangential movement, and generation 2 there is an axial movement. So this is a patent protected technology of mine, and we analyze the wet lab training versus novel surgical simulative training. So how are they both for especially novice mixed surgeons? So we approached many postgraduate institutes. It was an on-road workshop that I did, and 30 glaucoma fellows were actually enrolled, and they were all novice surgeons. 3 months of study from October to December, and were they adequately prepared for real surgical procedures is one that we asked after they underwent this. And this was a questionnaire first we gave, and then we went to a survey. So survey questionnaire, you can see it was adequately prepared, and you can see most of them, 31% were good and 38 were okay, and 22 felt it was still poor. Did the simulator help you in the hand-eye coordination? So especially in mix, the three-dimensional hand-eye coordination is what we emphasize on, and people were very satisfied for the spatial orientation. Then we went to the satisfaction levels. So we analyzed the satisfaction levels apart from the hand-eye coordination, and it was pretty okay. And did it give you adequate visual feedback? So visual feedback is another thing which is very important to inculcate ambidextrity or even three-dimensional simulative training. And you can see that 15 of them were actually felt it was good. And haptic touch. So in this simulator you can see that there is a haptic touch when you catch hold of the stent, or when you have any other procedure. If you are doing with this, we have many other surgical procedures innovated with this. There is a tactile sensation. It gives you a click sound in the ear, which really helps you in orienting towards space. It's called the pseudo 4D. So that also went well. Confidence in performing the procedure. Making mistakes. Does it really help you in making the mistakes or reduction of making mistakes? Accessibility. And many teaching institutes, if you see, they have Oculus, they have HoloLens, many have invested in their own simulator. Most of the teaching institutes have their simulator. It is just that it's in their lab and they are not using it. And does it create a safe environment? Very likely was the most positive responses we got. And do you recommend the simulator? There was an unanimous yes among the 30 users. The graphics and real structures were also very well taken up. And we also went for a cross-sectional study, a comparative study through Google Forms, especially using the realistic model, surgical planning and guidance. These are the components of the questionnaire: training and learning, safety and recommendation, along with the graphics and gamification features. Satisfaction levels among the 30 with the simulator and wet lab were compared with a simple pilot study. Satisfied, neutral and dissatisfaction, they were converted into continuous variables. The discrete variables were converted into continuous variables, and a pair t-test was done, and the p-value was significant. So resident satisfaction level during surgical training with the holographic one, they felt it was much better compared to the one that you had with the wet lab or the SSTC you can call. So it was definitely better. So this is, my dear friends, it's a pilot study. This is something which is medical virtual reality, which was unexplored, easily accessible. Most of the simulators are focusing on cataract and anterior segment procedures. Mix is something that is booming, and this is portable. Today here now you can actually, any one of you can come and get yourself oriented. It improves the quality of care, increases cost effective. It's highly cost effective, and we are also doing one in the smartphone as well. And we have used high resolution real time images, which gives you photo real interactive learning. And this is a free of cost simulator which is accessible, and we have already launched it. If you have a 4D simulator in your lab, it's just a matter of going and typing high space mg space HOLO, and the simulator is all yours. It's a MIGS simulator. So I think what was once thought to be a science fiction, my dear friends, it's not more a science fiction. It's all a science-based reality, and welcome to the world of 4D metaverse. And mix is something which is very close to my heart, and Vanita ma'am is here. She's a pioneer in mix. There is simulative learning like these will really help in bringing things out. So you can see the fundus is all real images, the angles are real. We are now working on a OCT filter. I think these kind of technology will really help us in refining our surgical skills, which will help you win the battle. Half battle will already be won when you are done not once but multiple times, and then you'll have a successful implantation or a successful KDB or a bang or whatever is your surgical choice of mix. So thank you once again for giving this opportunity.
Thanks a lot. I want just one clarification. You need the headset?
Yes, ma'am. You need this headset. For the pseudo haptic sensation, there is one sensation in your ear. It is coded in such a way. The headset is needed for a 4D experience, but with the smartphone also it is possible. Okay. But with that, you'll not have the 4-dimensional element. Okay. You'll use the phone as a stand. and only the 3D will be possible. Yes,
Thank you.
ma'am.
Thank you very much.
Yeah. Thank you, ma'am. Thank you.
Tanya Resh, and her topic of presentation is amniotic membrane umbilical cord grafts reflecting new rays towards glaucoma shunt surgery. She's not there? Then next speaker is Dr. Sai Vineet Maddu, long-term outcomes of ciliary sulcus placed Ahmed glaucoma valve in refractive glaucomas of Indian eyes. Is the next speaker there, Dr. Rupa Gupta?
A warm good morning to judges and my dear colleagues. I would like to present my thesis work on long-term outcomes of ciliary sulcus placed Ahmed glaucoma valve in refractory glaucomas of Indian eyes under the guidance of Dr. Devang, Professor Tanuj and Professor Vinay Gupta, and the study has been done in our center, RP Center. And as we all know, refractory glaucoma is uncontrolled intraocular pressure despite maximally given medications and non-Seton surgical procedures, in a combination of the both, and those which are at high risk of failure for further trabeculectomy. And in literature, we have seen the TVT study, the tube versus trabeculectomy study, at the end of 5 years had a cumulative probability of failure was 30% with the tube group versus around 50% with the trap group. Then it was known that GDDs seem to be promising for refractory glaucoma, but where are GDDs, AJV is one, AJV is usually traditionally put in anterior chamber, but what's the challenge with anterior chamber placement of AJV? Corneal decompensation and corneal related complications account for around 7 to 27% of complications in the literature. So what's the alternative? The alternative is we have two more paths. We can put it in ciliary sulcus or the pars plana route. What's the challenge with pars plana route? You go into the posterior segment, you have posterior segment complications and more vitrectomy need and inflammation. So it was already priorly established that it is advantageous to perform a ciliary sulcus among these three routes. However, we don't have any long-term ciliary sulcus AGV studies in Indian population, and especially the micro level. At the micro level, endothelial cell count changes is not established in Indian eyes. Okay, the aim of the study to evaluate long-term efficacy and safety, primary objectives being a reduction of IOP, reduction in number of medications, and longitudinally assess the endothelial cell density changes. Secondary objectives being long-term complications, and we also parallelly studied bleb morphology on anterior segment optical coherence tomography. We took a sample size of 15 eyes of 15 patients, and it's a prospective study. Inclusion criteria being 18 to 85 years of age and diagnosed case of refractory glaucoma, and no prior AGV or any tube surgery was done. And we have excluded the pregnant patients and pediatric patients. And our success criteria was IOP more than 5 and less than 21 millimeter of mercury, and around 20% reduction in IOP with no loss of perception of light and no need of any secondary surgery for the complications. Results, we have done 15 patients and mean age being around 30 years and length of median follow-up was 13.5 months. Clinical history, we have these primary diagnoses, most common being PCG or developmental glaucoma, which failed by the age they reached 18 or more, and there are 3 patients of this, and 2 each of silicone oil-induced traumatic and post-keratoplasty patients, and the rest are secondary glaucomas, including Ice syndrome, uveitic and Sturge-Weber syndrome, and complicated pseudophakia. So systemic history, none of our patients had any systemic history, and except one patient is positive for HLA-B27. Coming to the results, the significant reduction in IOP, nearly 49% from 33 mmHg to 16, and is statistically significantly reduced. And medications, number of medications were reduced from 5 to almost 0.92. And these are Kaplan-Meier analysis for survival, and the cumulative probability of success was 83% at 6 months, and 77% at 1 year, and 71% at 2 years. So some of the complications we faced are all the minor complications with ciliary sulcus placed. 2 of them had bleb encapsulations, and one of the patient, the one which I taught HLA-B27 positive, had an inflammatory membrane which got relieved spontaneously on starting her on QID dose of steroids, and one patient had a hyphema. There's one more issue which we encountered is most often when we place sulcus IOL, the tube gets misdirected behind the IOL, at times clogged with vitreous, but we need to reposition the post-op next day. So the one more coming to a secondary objective, we studied bleb morphology and intersegmentosity. We took a bleb height, bleb thickness, and homogeneity of the bleb to learn about them. These are serial follow-ups at 3 months, 6 months, 9 months, and 12 months. It was not a statistically significant result, but however, we concluded, we came to know that clinically thinner blebs were noted at the early follow-up, be it 3 and then 6 rather than later. We also used AIOCMTC as a tool whenever we had a doubt what is a successful bleb or which is going into encapsulated. Successful bleb, as you can see, there is homogeneously described well uniform bleb. However, encapsulated had thicker bleb walls, irregular bleb wall, and high voluminous bleb. So at a point when 4 to 6 months, whenever we had a doubt whether to go for a bleb needling or capsulectomy for the encapsulated blebs, we always use this tool or whether to continue topical medications. Coming to our primary objective, again, endothelial cell loss, we could make out 4.35% reduction in at 6 months and 7.12% reduction at 12 months. This is compared to the literature study which showed Andreselchus had 9.5% at 6 months and around 12.5% at 12 months. It's the work by Kim et al. Published in BMJ in 2016. They also published the cell loss in trabeculectomy, which is 1.5 and around 3 at 6 and 12 months. So I would conclude there is the success rate and for nearly 50% reduction of IOP and clinically relatively thinner blebs. And I would acknowledge my mentor and guide, Dr. Devang, Professor Tanuj, and Professor Vinay, and my alma mater, RP Center, and last but not least, my patients.
So AGV was the only type of tube used?
Yeah, ma'am. In this only AGV was used and it was FP7.
FP7 in all cases?
Yeah, ma'am.
All right. And all your patients had trabeculectomy before?
Yeah, ma'am. Yes, ma'am, they are failed traps. I defined refractory glaucoma then itself, like whatever diagnosis I have taken, they have failed trabeculectomies more than 2 or 1.
Even the secondary glaucomas, they
Yes,
had
ma'am.
traps before?
Yes, ma'am.
Okay. Where did you target your endothelial cell count?
Ma'am, it wasn't localized, but more often near the tube. More often we placed it at superior temporally, the AGV tube. Near the superior temporal, we took the specular counts.
So do you think one region like that, where you have a foreign body there
Yeah.
and expect a reduction, do you think just taking in one quadrant gives you
Adequate
information?
I do get it, ma'am, but the losses for the corneal endothelial cell count is not just the target area. Whenever the patient moves the eye or forceful rubbing, the tube is moved in and out. And even the opposite area, superior nasal, inferior nasal, the gush of the fluid from the aqueous gush versus the heart rate or pulse is also related in literature. So it showed that these are the reasons for endothelial cell loss. It's not just superior temporal quadrant. There is one limitation. We just compared one area. I do agree, but diffuse we couldn't take because most of the patients had post-traumatic, post-keratoplasties where we couldn't capture the specular counts.
So there were patients where you could not capture?
Yeah, ma'am, I did mention only 10 patients we could, out of the 15, I could only mention 10.
Okay. Thank you very much.
Thank you, ma'am.
Thank you very much. That concludes Glaucoma 1 AIOS free paper session. Thank you, guys.